This is Chapter 23, Part 1, The Child with Cardiovascular Dysfunction. So what's the incidence of congenital heart disease? It's about 5 to 8 infants per 1,000 live births. And of those, 2 to 3 are symptomatic in the first year of life. At the hospital, all the ones you're going to see are those more severe kids who are in that 2 or 3. But if you notice, there's more, at least half, if not more than half, that are never seen in the first year of life or never diagnosed. So congenital heart defects or congenital heart disease is one of the major causes of death in the first year of life. Prematurity is the leading cause, and then it's also right up there after that. The most common anomaly we see is a ventricular septal defect. That's an opening between the right and the left ventricle. And those are ones that we usually will wait, because if they're small, they can close up on their own. Now, at least a quarter, 28% of these kids have some other anomaly. So there's something else going on, and the heart defect is just one piece of it. So we can classify cardiac defects as congenital, which they're born with, right? There's some anatomic problem that the heart just didn't close, didn't come together correctly, the 4 chambers didn't form, or it can be acquired. So it can happen after an infection or autoimmune response, or some sort of environmental factor can cause it, or then a familial tendency to develop heart disease. So of kids who have congenital heart defects, there is a chromosomal cause in 10 to 12% of them. Other things are maternal or environmental causes. So this is some exposure that they got, and about 1 to 2% have this. Could be maternal drug use, and particularly fetal alcohol syndrome. About 50% of the kids with fetal alcohol syndrome will have a heart defect. Illnesses, rubella, especially if mom gets an initial infection in the first 7 weeks of pregnancy, 50% risk of a defect. CMV, cytomegalovirus, toxoplasmosis. Toxoplasmosis is the one we tell pregnant women not to change litter boxes because of that one, or other viral illnesses. And remember, it's specifically or especially if it's while the heart is forming, which is all in those first weeks of pregnancy. Infants of diabetic mothers have a much higher risk, and part of that, we know those high blood sugars are teratogenic. They predispose birth defects. So it's real important we get those diabetic moms, their blood sugars under control. And then the majority of the time, 85% of the time, it's multifactorial. There's not just one cause, but many. So what are you going to be looking for? Failure to thrive. We want to see if this child is eating adequately and not growing. Can be a sign. They're not circulating the nutrients well. They are not getting oxygen and nutrients out to the tissue. They're not going to grow. Color. If they're cyanotic or pale. A chest deformity. Infants have a more rounded chest than adults, but some of these kids, their chest, you look at it and it's not even a normal baby-shaped chest because their heart is so enlarged. Unusual pulsations in the neck veins, that is hard to see on infants because they don't have much neck, so it's hard to see those jugular veins. Respiratory excursion, they're going to be tachypnic or have grunting. So at the end of expiration, it's kind of a way of doing a natural peep, or we teach some of our adults to do pursed lip breathing. It's sort of a natural way of doing that grunting. It comes at the end of expiration. And then clubbing of the fingers. You've got to be hypoxic for a good 6 months to get your fingers and your toes to club. So let's remember normal fetal circulation. The first breaths open up all those alveoli, they open up all the capillaries and really change the pressures. So in utero, there's the umbilical arteries and vein. Once you're not using the placenta, nothing's going through those. So those close instantly and automatically. The foramen ovale is an opening between the right and the left atria. As those pressures change, remember in utero the right side is higher pressure, but once you start breathing, you really drop the pressure on the right side of the heart, the pulmonary vasculature. And so the left side very quickly becomes higher pressure and it closes that foramen ovale. And the same thing with the ductus arteriosus. That's a connection between the atria and the pulmonary artery. And when those pressures change, when a baby's breathing for themselves, they have a higher pressure of oxygen in the blood than when it's happening to cross the placenta and just diffuse from the maternal blood across the placenta to the baby. So their oxygen pressure goes up, and that is a piece of what causes the ductus between the aorta and the pulmonary artery to close. And and here you can see it. Here's the ductus arteriosus in utero, which then closes and just becomes a fibrous ligament. We have the opening here, the foramen ovale, which closes, and then from the placenta here, which again becomes just a ligament. Okay, so history that we're going to want to ask about on a kid who may have cardiac dysfunctions. We want to know about the symptoms and when did they occur. In a severe defect, it's going to be very shortly after birth, but it can be up to 4 to 12 weeks after birth, especially if they aren't symptomatic till they start developing some heart failure. It may take a few weeks to a few months. But again, we're going to see that poor growth, failure to thrive, poor weight gain, activity intolerance. This is a baby who gets tired. They just can't circulate oxygen. If normal babies cry for a while, they just breathe harder. This is a baby, they don't have that ability to kind of compensate when they have increased oxygen demand, like a crying spell. It's going to make them delayed. They're not going to develop those motor skills, partly because of the activity intolerance. I mean, they don't have the energy. Prenatally, if there's a good ultrasound done, we should be able to see some of these defects. And if there's a family history, we used to think there was no family tendency, and then we started correcting these heart defects, and those kids are now living into adulthood and having children, and by golly, we're finding a family history. So there is a family tendency. So physical indicators: poor feeding, tachypnea and tachycardia, diaphoresis, especially on the head. Their heads can be wet from sweat. Crackles in the lungs, hepatosplenomegaly. This just says hepatomegaly, so enlarged liver, but the spleen as well. Cyanosis, listening to a murmur. A sternal lift is you put your hand there on the point of maximum impulse and you can feel it. So some of the testing that we use is an echocardiogram. This is great because it's very non-invasive. There's no pain to it, no side effects to it. This is your ultrasound. We just put the gel on the baby's chest and they can look at the heart. They can make it sense oxygen, so they can see what's oxygenated blood and what's deoxygenated blood, and then they can see if one is mixing in a way that it shouldn't. With this, to get a good reading, the child does have to lay still. Usually babies are okay with it, but but occasionally you may need to do some sedation. If this is an older kid, think of some way to distract them. A TV show, a movie, something that they enjoy, that they can lay still and let the test be done. Cardiac catheterization, just like you see in adults, it's the same thing with kids. However, we frequently use the femoral vein or artery rather than just, in adults it seems like it's in the arm the majority of the time. We can do the arm, but we often do femoral. Just either will work, and I don't know if that's physician's preference or if there's a reason, but you'll see a lot of femoral. So things we're watching for if a child comes back who's had a cardiac catheterization is bleeding from the site. And if you think about it, when they puncture, they're puncturing at an angle. They puncture the skin and they're going at a 45-degree angle till they hit the vessel. So if you get bleeding, you're going to put pressure, a couple of centimeters, an inch or so above where the puncture on the skin is, because you want to be right over where the vessel actually is punctured. A low-grade fever, we're of course watching for infection, but that can just be a reaction, especially a reaction to if they use dye. Some people get that. Nausea and vomiting can be a reaction to the dye or the sedation meds they use. A loss of pulse in the catheterized extremity. So you're wanting to check the pulses below whichever side was catheterized, and you're going to check it compared to the other side. It is possible to lose that pulse. That is not necessarily a medical emergency. It's absolutely something we're going to pass on. But where the vessel was punctured, particularly if they did an arterial cath, you could get some swelling there. It could pinch off what you're looking for below. Most people have adequate collateral circulation that will make up for that. So it is something to pass on, but it's probably something that's going to be monitored to make sure that it's temporary. And then transient dysrhythmias. This is also something to pass on, but not necessarily a concern. If you put a catheter inside your heart and let it bump around, it's going to irritate spots. And then you'll start getting these little ectopic beats started from those irritated places. So we're watching that. We're making sure it doesn't turn into a significant arrhythmia, but it's kind of, it's not something we want, but we almost expect it. We're not too concerned. We're just going to monitor it. Let the physician know, of course, but then it's probably something that will be monitored unless it really turns into a significant dysrhythmia. Nothing was without risks, right? So significant side effects are very rare, but you can have a stroke, seizures, tamponade, or death from a cardiac catheterization. And I have some pictures here. Remember, we can go either right or left. You have a vein and an artery on either side, so which side they pick has nothing to do with whether they go in the vein or the artery. And then they're going to thread it up. With adults, they're almost always trying to do this, thread up through, kind of coming against the flow, right, backwards through the aortic arch, and they're trying to check the coronary arteries. That is usually not what we're trying to check on kids. So we're more likely to be looking down along the septum here between the two, and then this one came up through the vein, right? So this is the vena cava. Again, this is femoral, so we're coming up through the inferior vena cava, and our concern usually is a opening we don't want between the atria, the ventricles, or all of them. So they're looking at the pressure and the oxygen, and if you look at it, every little millimeter, they're looking at what the pressure, what the oxygen is, and they can identify exactly where and how big a defect in the wall is.